We opened up the pharmacy in the MOB across the street, across 9th Street. That opened up May 22nd of this year. I was on the team for the entire build, licensure, and certifications, and getting all the stuff ready to go. So we opened up in May, and we've been having great success ever since then. So again, I am a retail outpatient pharmacist. I am not as clinically oriented as some of my colleagues on the inpatient side are. So I deal a lot more with the outpatient and dealing directly with the patients. So that's really how I did set up this presentation, is to really kind of show everybody on the inpatient side what I see on the outpatient side, and what really matters to us with the tenets of good opioid prescribing, as well as some of the laws that are going to be the major portion. But we're also going to go through just pain in general, just kind of a little refresher here. So again, pharmacy manager here at St. John's Community Pharmacy. I have no potential or actual conflicts of interest to disclose. And we'll go over the objectives. So the first thing that we kind of want to touch on is how pain arises and how to classify certain types of pain. The way in which pain is classified will have an effect on how we try to treat it. Describe ways in which to treat pain safely and effectively. Discuss good opioid prescribing tenets. Also review the specific laws pertaining to controlled substances. So like I said, the very first thing that we're going to do is we're going to say essentially what is pain. What is it that happens in our body that we receive these thoughts of pain, and how does it arise within the body? After that, we're going to go a little bit into how do we treat pain. So once the pain happens, how do we treat it? After that, we're just going to look at some of the medications that we're going to be treating, and then at the end, for the majority of the latter portion, we're going to be talking about safe prescribing habits and laws pertaining to it. So kind of just to start off with, we want to talk a little bit about the statistics involving opioids and the opioid epidemic. I'm sure we've all heard that in the news and all the literature that we subscribe to, is that opioid overdoses and fatalities are an epidemic currently in the United States. On average, about 130 people die every single day from opioid overdose. And even if we have some acute pain within the inpatient setting, we're just giving them a few days worth of medications. 8 to 12 of those patients can develop, or have been shown to develop, an opioid use disorder. And the opioid use disorders are where we're seeing the addiction and really the drug seeking that a lot of us have experienced. Roughly 80% of heroin users first started with the prescription opioids. They come in for an acute pain, a broken leg, a minor surgery. They get these medications, and then they can't get them anymore. They can't get their doctors to prescribe them. So how do they go about getting that high again? They go to heroin. An economic burden of $78.5 billion per year. So this is taking into account medical costs, missed work, and things like that. So it is a very large problem that we're dealing with. That has been around really since the early 1990s. During that time, the big pharma companies reassured the medical community and our prescribers that you can't get addicted to these painkillers. It's going to help your patient. They're going to feel a lot better. No risk. Don't worry about that at all. So they started prescribing a whole bunch of opioids for everybody, right? Giving them for a longer period of time than necessary, higher strengths than were necessary, because they were assured that not a problem at all. But this led to widespread diversion and misuse. We're saying that as of now, up to 21 to 29% of all patients that are given opioids misuse them. So what's misuse? We're talking about patients that take too much at one time to get that high. They're selling them, they're sharing them, things of that nature. And of those, the 4 to 6% of those patients that do misuse these prescriptions transition to heroin. And again, that just continues the snowball effect, and then it spirals out of control and adding to that economic burden that we're seeing. So this is showing a little bit of the opioid overdose trend between 2016 and 2017. The arrow is pointing to the Midwest, which is a little bit scary. So we were kind of right around third place, and now we're near the top. It has been an absolute explosion here, and I can say from the outpatient side, from the retail side, it's scary to see how many opioid prescriptions come through. And these people, they're laughing, they're joking with their friends, and they're getting 4 weeks of opioids for something that was super minor. At least on my side, obviously we don't have all the information on the inside, but they're just getting a ton of that, and those, if you're getting all those medications, it just can lead to those misuse and sharing and selling and things of that nature.
So why do you think that happened in 2017? Is it just because of the huge push of the doing that, having to do the prescription electronically, that we were kind of, what do you think happened there?
I think that could be one possibility. I think it's another possibility of people realizing that they can push their prescribers to get them as well. I think that has a big part of it, because this opioid epidemic has been around for a while, and they say, oh, well, my friend Johnny down the street yelled at his doctor to give him some hydrocodone. I'm going to do the same thing. I think that could be a possibility, and it could also be a possibility of prescribers saying, like, this is what my patient needs, and prescribers really wanting to take care of their patients. But the only way that we have to tell if a patient is in pain is if they tell us. We can't run a test. We can't do these things to show that the patient is in pain. All we have to rely on is them telling us, I am in pain. And sometimes people aren't always truthful. And I think people found that out.
I was just at a multidisciplinary critical care conference, and there was a huge discussion about this, obviously, and they were talking about how the push for, the patient satisfaction and all of that was a huge driver in this, as well as, patients' perception of their, what is acceptable pain, or pain around the time of procedures and things like that you're not going to have zero pain.
Because we have to have those top box scores,
Yeah, exactly.
We have to make everybody happy. How do you make people happy? You give them what they want, and they want payments.
Yep.
So just kind of I always wanted to show the trends and show that it is a problem within our current state. So now that we've proved a little bit that there is a problem with the opioid epidemic, let's talk about why are we needing opioids? What is it treating? It's treating pain. So I want to go into a little bit of a summary of the kinds of pain that arise within the body, get a little bit of the pathophysiology, just so we can kind of go more into how are the prescriptions working. We have to know, what are they working for? What is the problem that we're trying to treat? The first thing that we're going to go into is adaptive pain. This is probably what most people think of when they think of acute pain. So this is when something hot, cold, or sharp is touched. So if you cut yourself, if you burn yourself, get some frostbite, the body, or the pain receptors, and they're called nociceptors, they react to these, what we call noxious stimuli. So stimuli that is harmful to the body. Again, those cuts, those scrapes, those heat, and it causes a sensitization at the site of the injury. When that happens, the body can also exhibit a inflammatory response as well. So that's when we're seeing the redness, the swelling, and that's to promote healing within the body. That's our body's natural way of saying, hey, there's a problem here, let's go fix it. But within that, can also kind of cause some more pain. So we're going to go into the steps of adaptive pain: transduction, conduction, transmission, perception, modulation. This is going to take us from the very first point of that noxious stimuli, that cut, that scrape, that burn, all the way to, wow, this really hurts. So that's what we're going to go into next. This is a picture I'm going to be referencing. It's just going to be showing us kind of where we're at within the pain pathway. On the left-hand side, you can see that the patient here has had a cut. You can see the nociceptors right there with a lot of the neurons going from the skin through the spine and up to the brain. So this is kind of what we're going to be looking at when we're talking about the pain pathway of adaptive pain. So the first thing that we're going to get into is transduction. This is the very first thing that happens within the pain pathway. The nociceptors, like I said, are the pain receptors on the periphery of our body. They're the things that are sensing these noxious stimuli. And again, we've already talked about mechanical, thermal, and sometimes even chemical means. And at that point, once we have those, and that's again happening right here at the cut, we're going to be getting more into the conduction portion. So this is when those nociceptors are setting off all those neurons in our body, and they're firing off action potentials. And this is sending the signal from the skin all the way into our nervous system at that point, our peripheral nervous system. Once we get through the conduction portion, we're getting to transmission. And that's where, once we have those neurons kind of releasing all of their potentials, we're getting neurotransmitters within the body released as well. So this is more happening between the skin and the spinal cord. There are certain transmitters that will be released, such as substance P or glutamate. and those will kind of transmit that pain, that sensation of pain, all the way up and through the spinal column. Next, we're going to have perception. So this is when the pain sensation is really reaching the brain. And in this portion, science has not really advanced far enough for us to understand how all those substances and all those signals are really kind of amalgamated into the feeling of pain. But this is where it happens. And it's really interesting that certain cognitive behaviors can kind of modulate this. If you've ever had a kid getting a vaccination and you have one of the doctors that will try to distract them, right? You have something, look over here while you're giving them the shot. They may not really sense it as much. And sometimes when I'm giving vaccinations to some of my adult populations, I do the same thing. I'll ask them, so how are you doing today? Have any kids? What's your favorite sports team? And while they're talking to that, I'm giving them the vaccination, and then they're like, oh, are you already done? Absolutely, it's distraction, right? Because if you're not expecting that pain, if you're not preparing yourself for that pain, sometimes that pain can pass right through you, and we're not going to have those sensations. In the same kind of aspect of this, there are certain things that can increase that pain. So if you see some of our patients that have especially depression and anxiety, they are more apt to feel pain because their brains are already in the mindset of, I'm going to be experiencing pain every day, I'm in pain right now. Even if it's not physical pain, it could be emotional pain. And it's just preparing them already to have, once they get the slightest hint of those signals and those neurotransmitters popping off, their brains are always like, okay, this hurts. I got to get it to stop. I can't deal with this. This is not something that my body is able to deal with. And that just kind of upregulates all those things, and you feel that pain so much more intensely as well. So it's kind of an interesting way that our brains can both increase and decrease the feeling of pain right there. And modulation is kind of the final step. So if the perception part is the cognitive part, the modulation part is more the physiological part. So this is where the brain, by releasing neurotransmitters, can upregulate or downregulate pain. So if we're releasing the excitatory neurotransmitters, like the substance P and glutamate that I talked about already, that's going to increase that feeling of pain. It's almost like a positive feedback loop. Pain happens, excitatory neurotransmitters are released, that pain's increased. Otherwise, we can do things like norepinephrine or serotonin can be released, and those can downregulate that pain. You always hear those stories about a car crash and a child being stuck under a car, and the mom will get out and literally lift that car up so that baby can get out, right? She's feeling pain right there. She was in the same car the child was. But we have all of these neurotransmitters, this dopamine, this epinephrine being released, that we can do these things, and it blocks those pain receptors so that we can progress with the situation and get to the other side of it. So it's more of a survival mechanism almost, in that we can block out that pain by releasing certain things. And also with the norepinephrine and serotonin, that's where we see some of the tricyclic antidepressants. If you ever heard of amitriptyline being used for pain, or SNRIs, such as like venlafaxine or things like that. Those regulate dopamine and serotonin, norepinephrine, things like that. So if we're regulating those and we're having those more in the neuronal space, that means that we are really downregulating the perception of pain. So that's kind of how those are working. So we're going to get through the adaptive pain, and now we're going to get to the more what's termed maladaptive pain. This is mostly what people are thinking about when they talk about chronic pain. It's much harder to diagnose and treat this kind of pain because it's not caused by that cut, that scrape, that burn, or frostbite, what have you. It's really a result of the malfunctioning neurons in the system. And a lot of times people complain of burning, tingling, or shocking sensation. A lot of times that's more the neuropathic pain, which is one part of maladaptive pain. But really what we're looking at in this is that the neurons themselves can almost, they upregulate themselves. You know, there could be more within that system, so that whenever there's any kind of pain happening, there's more of them to fire off, so we get more of those feelings. Or maybe it's the fact that it takes a lot less for them to depolarize, for that signal to be sent. So if something that may not cause pain in you causes pain in me just because my cells are more apt to fire off, it's kind of it's one of those things where the neurons themselves are more likely to send those signals of pain, so you just keep on getting the chronic pain that kind of just malaise all across the body, whereas I may not know exactly where it hurts, but I just know it hurts. And again, with the maladaptive pain, we don't see the toe, we don't see the scrape, so it leads to a lot of undertreatment as well, because again, all we have to rely on is them telling us we're in pain. If I can't see that you're in pain, if I can't see your broken bone, or if I can't see your burn, it's a lot harder for us to treat that. But sadly, this is why a lot of the people in chronic pain, they never feel like they get that relief because it's so hard for them to put it into words almost. Again, getting more into the types of maladaptive pain, the neuropathic is what I've kind of mentioned already. This is really the diabetic neuropathy and the post-herpetic neuralgia. This is really the damage to the nerve endings, and that are more likely to shoot off those pain signals. And then as well as the centralized, where there's really no nerve injury, but sometimes those excitatory neurotransmitters like the glutamate and substance are just more in the system, so you get a lot more positive feedback from those and causing the pain. And we're looking at this for the fibromyalgia, the IBS, and even some like chronic tension headaches as well. So again, a lot of those syndromes are harder to treat because it's harder to pinpoint the exact etiology of the cause of it, and that's why just sadly, like I said, these people have sometimes a hard time really getting control of their pain. So we kind of already touched on this a little bit, but kind of just to nail down acute and chronic pain. Acute, we usually, again, are adaptive in nature, short in duration. We're usually talking about less than 3 months. I've seen some papers say up to 6 months. And again, can usually be ascribed to a specific cause: acute illnesses, surgery, trauma, labor. Chronic pain persists past that 3 to 6 months mark. We're usually talking months to years. Really hard to get that cause, as well as a lot of times it's divided into cancer and non-cancer pain because of the way that you treat and the way you look at it's just a slightly different, like again, most of the time a result of the nerve function or transmission damage.
So is that arthritic pain falling into the chronic,
Usually,
but it's not in the maladaptive, is it?
no, so that's why I say that adaptive is usually acute pain, but it doesn't have to be. So, the adaptive pain, we know the cause of, we know the etiology, but because we're lasting longer than that 3 to 6 month period, we're probably going to be classifying that in the chronic pain category. Yep. Which brings us to our first quiz question of the day. I've said this about 45 times, so I hope somebody will be able to answer it, but nocture stimuli are most associated with what kind of pain? Adaptive, maladaptive, chronic, neuropathic.
Make sure you fill that out on your quiz, because you'll turn it in.
Oh, we have quiz. Yes, it is adaptive. Alright, so we've kind of gone over what is pain and how does it arise in our body. So let's talk a little bit about how can we treat pain. A little bit further in the presentation, I'm going to talk about good tenets of opioid prescribing, which is going to talk a little bit about non-pharmacologic treatments of pain. So with this, we're talking about physical manipulation. So we're talking about therapy, hot or cold, relaxation, exercise, TINs. If you've seen the TINs with electrical stimulation, sometimes that will help as well. When I'm looking at the non-pharmacologic approach, everyone's like, oh, that doesn't work. I just need hydrocodone. I just need oxycodone. No. Look at some of our our most intense athletes, right? We're looking at football players, basketball players, track stars. What are they doing after a game? They're going to hot tub, they're going to cold tub, and they're going to go get a massage. Why? Why? Because it works. They don't need to be on these pain relievers that could reduce their ability to do what they need to do. They're doing all these other things that doesn't make them take in these medications to their body. Yes, I'm a pharmacist, but I'm trying to get people to stop taking drugs, okay? So really these things are what our highest paid athletes are doing, but why can't we coach some of our patients to do the same thing? These are free. Go take a cold shower, go take a hot bath, go get your kid to give you a back rub, you know what I'm saying? So it's one of those things where these things are a lot of them are completely free. Exercise is actually a huge part of this. Exercise has been shown to reduce pain and osteoarthritis in the hip and the knee, and besides that, it promotes a positive self-image, so we're getting some of that cognitive effect, right? And sometimes it can be distracting as well. If you're like, oh, I gotta walk this other mile, you're not really thinking about that headache that you had an hour or two ago. Like, all right, got another mile, the birds are chirping, everything's great outside, right? And another thing I kind of want to kind of point on is acupuncture. I actually spent a month in China kind of studying traditional Eastern medicine, and coming from a Western society, when you're going over there and you're seeing the cupping and all the herbal therapies and things like that, it's really hard for us to understand how that works, right? It's very odd to us. It's very strange. I saw an older man walk in with a very heavy limp. We were actually talking with one of the physicians that took care of the prime minister, a previous prime minister. So we were talking and we were watching this physician treat this man, and he walked out without a limp by sticking needles in his forearm for his limp.
Oh, wow.
It was extraordinary to see, but at that point I'm thinking, is he treating the body or is he treating the mind? Because I think a lot of those things, the mind is a very powerful tool. So if we can make people see that, it's not always about taking these pain medications, but let's treat the whole body instead. Let's go a different route. Sometimes the brain can follow in that way and treat them almost as well as anything else. So, picture of where I would normally work, over here in the OTC aisle, and not all these are over-the-counter medications, but quite a few of them are. So we're going to be looking at things like aspirin, acetaminophen, ibuprofen are big over-the-counter hitters, right? And it's actually been shown that, especially in things like osteoarthritis, NSAIDs are really going to be first-line therapy for that. That's something that we should be trying first instead of jumping straight to opioids. And then we have some other NSAIDs on here, like the diclofenac, naproxen, ketorolac, celecoxib. So these are all medications that we can try to start our patients on before we jump straight to the opioids. Obviously, there are always going to be cases where this patient needs an opioid, and that's okay. But if we're having a short-term thing, do you think that we could maybe try something else first and see if that's going to work before we jump straight to the opioid and we have all the problems that opioids can bring with it? So with how the NSAIDs are normally working is they're inhibiting prostaglandins, which is really inhibiting that inflammatory response and causing some of that pain. So if we can inhibit some of those inflammatory responses, a lot of times that will take care of the rest of the pain. All right, let's move on to the good stuff, what everybody came here for. I just listed off 5 of the more common ones that we would probably see, at least on the inpatient side: hydrocodone, oxycodone, morphine, hydromorphone, and fentanyl. It's probably the ones that I will be referring to the most throughout the rest of the duration of it, because this is probably the ones that we're seeing the most on the inpatient as well as on the outpatient on my side as well. So how do these things work? We know that they make our patients stop yelling at us and be a little happier, but how do they actually work in the body? So they are acting on opioid receptors, and on those opioid receptors are tied to those pain receptors, in that they decrease the ability of those pain receptors to shoot off. So if we're inhibiting the transmission of those pain signals, we're reducing the formation of pain in the brain and overall the feeling of pain in general. So with this, which ones are stronger and which ones aren't, and why is that? Because these medications, they bind to those receptors with varying affinities. So some medications will bind to those opioid receptors very, very tightly, and those are what we call strong or full agonists at the receptor side. Some medications will bind to those receptors, but not completely, or are not nearly as strong as some of our full agonists. And that would be something like a buprenorphine. Buprenorphine and naloxone is something that a lot of patients will be on if we're trying to treat opioid use disorder in that way. And then we also have antagonists. So what are medications that will bind to that opioid receptor site and prevent anything else from binding there and creating an opioid response? And that's naloxone. So that's something that has made a major push within the last few years to try to help with the opioid epidemic. And those are some of the things that we're going to be talking about as we go on. So I just want to do a few quick slides over the more common opioids that we're going to see. Hydrocodone is probably the one that I see the most on the outpatient side. Again, almost always combined with acetaminophen. There are some extended release hydrocodone products out on the market. It's not something that I even carry, because I think I may have only seen 1 or 2 prescriptions for extended release hydrocodone in the 5 years that I've been practicing pharmacy. Oral onset, we're going to be 10 to 30 minutes, and again, most commonly used in combination. So if we're looking at a pain scale and we're getting right around the 4 or 5 mark, probably something that we can turn to would be a hydrocodone product. This is something that once we've already tried our non-opioids treatment plan, but this is going to be really our first step into the opioid world. It's going to be one of the least potent, but still very effective medications. So next we're going to talk a little bit about oxycodone. This is when we're kind of getting into that 5-6 range on the pain scale. We use in moderate to severe pain. The onset can be 10 to 15 minutes, so we're looking at probably a shorter average of onset, but it can still be around the same. A lot of times on the outpatient side, I've seen the ER and the IR formulations, immediate release and extended release formulations used for chronic and breakthrough pain. So if we're doing around-the-clock dosing, we'll be giving oxycodone ER and then oxycodone IR for breakthrough pain. A lot of times we see that for cancer patients. Again, most commonly seen with acetaminophen, we're going to be seeing the oxycodone and acetaminophen combination products that shares the same basic morphine characteristics as well. Probably the second most common thing that I see on my side. Morphine. Everybody knows and loves morphine. It's probably one of the more popular ones that I've seen when I'm at least in patient charts. Severe pain, cancer pain, we're probably looking around that 6, 7, 8 mark on that pain scale. A lot of times we're seeing this in the cancer areas. Again, the ER for around the clock problems, and then the IR for breakthrough pain. Fairly quick onset, IV 5 to 10 minutes. Oral is going to be 30 minutes. Caution renal impairment. If we do have renal impairment, we probably need to be looking at adjusting that dose, just to because the patient can't eliminate that medication as effectively as some of the other ones. We just need to make sure that we are dosing them appropriately to watch out for any of those adverse effects. Can cause venous and arterial vessel dilation, resulting in orthostatic hypotension. The patients that we're seeing this the most in are going to be the patients that are hypovolemic as well. So we need to especially be on watch out there when they're going from a laying or sitting to a standing position, making sure that somebody's watching them for fall risk, or making sure we're teaching them how to stand up with a hand on something just to make sure we're safe. Cause a decrease in myocardial oxygen demand in ischemic cardiac patients, MONA, right? So morphine is going to be used in there. And histamine release is causing pruritus or bronchospasm, and morphine is probably the worst offender at this. When that histamine is released, it causes really severe itching, and then that histamine can also cause, like I said, bronchospasm in our pulmonary system, and have problems, trouble breathing. So with this, a lot of times if we do know if morphine is what we have to give, and we have a patient that has to have morphine, taking an antihistamine with it can kind of help us. Or if we don't know that it's going to happen and that pruritus does happen, giving them something like a diphenhydramine or something is really going to help these patients. Hydromorphone, again, we're kind of climbing up that scale. We're kind of getting around probably around the 8 or 9. Used in severe pain, onset, 5 minutes IV, 15 to 30 oral. It's mostly mimicking the profile of morphine. We're just getting to be a little bit more potent here. Less milligrams, but we're getting the same effect, if not better. Don't see a ton of this on the outpatient side. We're seeing that a little bit more, especially in the OB world. But again, it's not something that's too common on my side. And fentanyl. Fentanyl, quick on, quick off. So what we know that is a quick onset, almost immediately IV, transdermal with that patch. We're going to be looking about 6 hours. And a lot of times prescribers will like this because it does have that quick off. So if there are any problems, it's not going to be sticking around in the body quite as long as some of the other opioid medications. Severe pain, chronic pain, cancer pain, we see a ton of this in cancer pain just because we can put it on that patch and our patients don't have to be taking all these pills around the clock all the time, because the pill burden for especially chronic or cancer pain can be huge. Caution opioid naive patients. If our patients have never had opioids before, this one is extremely potent medication. We need to be very careful about things like respiratory depression and just somnolence and a lot of the other adverse effects. And I put all the drug formulations on here just to kind of show you how almost unique this drug can be. IV, IM, patch, lozenge, film, tablet, intranasal spray, sublingual spray. I've seen IV, patch, film, tablet, and spray on the outpatient world in one way or another. So it's a very versatile drug, and it helps out a lot of people who have our most severe pain. I want to talk a little bit about the fentanyl patch. This is something that I don't feel like our patients, at least when they come to me, they seem to know a lot about. Where are we going to be applying it? Chest, back, flank, or upper arm? Really, we're looking for anywhere with a flat surface, and if we can, try to get a hairless surface as well. We cannot shave a hairless patch on a patient because that will irritate the skin. And if we irritate that skin, we put that patch on it, we could get a much higher absorption rate of that medication. So if we do need to clip it, or if we do need to take some hair off a patient, we need to clip, we can't shave. And we need to be doing the upper back in people. So if we have cognitive impairment, so we have a cognitive impairment and chronic pain, putting it somewhere where they can't reach. Because if they do take that patch and they do try to do anything else with it, or they apply it somewhere where they shouldn't be, where they have open skin, which increases the absorption rate, we can have a lot of problems with the adverse effects. Applying that patch to a new skin site each time, again, is because of the absorption, because that skin can be a little bit irritated with wherever we apply that patch. So we want to apply it different places each time. Kind of like with enoxaparin, we want to be giving it in different places because we could have induration at that site. The patch, we just need to be moving around for any kind of skin problems. Heat sources can increase absorption. Problems with adhesion occur, we can always tape it. And then just telling our patients safe disposal of these patches, because I've sadly heard some stories about pets, or even once I heard a kid getting into the trash and finding these patches, and that's terrifying. Because you get a kid that has never had an opioid in their entire life, they get a hold of these patches, it can be fatal very easily. So what we try to counsel our patients on are folding the sticky sides of the patch together, putting it into the toilet, and then flushing it down, and making sure that it does flush, because again, if it doesn't, a dog drinking out of the toilet bowl possibly, or a kid messing around in there can find that and try to play with it, and we just want to be very careful with that. I want to go a little bit into we talked a little bit about potency. So morphine and hydrocodone potency, at least at the low dosages of morphine, are fairly similar. Oxycodone is going to be a little bit more potent. Hydromorphone more potent still, and then the most potent is going to be our fentanyl patch. So again, these are the doses that are going to be equianalgesic. So these doses should equal each other out. Brings us to our next question. Which of the following is the most potent opioid of the group? Fentanyl, morphine, hydromorphone, or oxycodone? Fentanyl. Everybody's paying attention. I'm so happy. All right, so we talked about our opioid agonists, things that do bind at the opioid site fairly strongly. Now let's talk a little bit about naloxone, which is an antagonist. So it goes to those sites, and it makes sure that the opioids can no longer hit that opioid receptor site and have its effect. So when we're giving our patients naloxone, if they have an overdose situation, this is what the medication is doing. It's going into the body, it's going to those sites where those opioids would normally bind and saying, no, you can't be here anymore, this is my spot. And when it does that, it takes away those adverse effects of drowsiness, somnolence, respiratory depression, because it's saying, no, I'm here at the opioid receptor now, you can't be here. So most normally on the outpatient side, we see intranasal with the 8 to 13 minutes. We can repeat the dose every 2 to 3 minutes. Every dose is a 4 milligram, I believe, at least intranasally. I think we can give up to 10 milligrams. And sometimes we may actually need to be giving this, even if it works the first time on the very first dose, we may need to redose in 20 to 60 minutes because the half-life of naloxone is a lot shorter than some of our extended release products, such as methadone or ER morphine or something like that. So because those stay in the body so much longer, the body could process that naloxone and get it out of the body, and then we're going to have a problem with overdose again because the opioid is staying around a lot longer than naloxone. And it is caution for an opioid withdrawal, which we'll talk about in a little bit. So true or false? Fentanyl is an antagonist at the opioid receptor site. False. Correct. So the only antagonist we talked about would be the naloxone. Fentanyl is one of the strongest agonists, the strong affinity there. All right, adverse effects. Somnolence, just kind of feeling out of it. Respiratory depression is a huge one. Decreased GI motility. Of a lot of our opioid patients are going to be having problems with constipation. So recommending over-the-counter products or prescribing over-the-counter products such as polyethylene glycol, one of those bulk laxatives, or the DocuSate, or sometimes even in our more problematic constipation cases, Visicoldal as well. Those are all ways in which we can treat or we can try to prevent, the problems of constipation, because preventing is a little bit easier than treating, and it does take a little bit short amount of time as well. The histamine release we've talked about, sometimes taking a diphenhydramine to counteract that. Mood changes and stimulation of chemoreceptor triggers zone. A lot of people have nausea with opioids, and for some reason they'll trigger the zone and they'll cause that nausea. A lot of times we'll see kind of Zofran to treat that. Ondansetron to treat that. But at that point, we're treating one pill with another pill, and that kind of has its own problems. So. And three of the big ones here, more of the common to these prescriptions as opposed to a lot of the non-opioids. Tolerance, giving a patient the same amount of medication over and over again, but the patient having less and less effect with it. Physical dependence means if we're having a patient that are on these opioids and all of a sudden we take them away, they're going to have problems with nausea, GI motility. They can have flu-like symptoms, and we're talking about really withdrawal there, withdrawal symptoms. And then addiction, which is probably one of the main forces for this opioid epidemic, in which the brain rewards itself for having these opioids, and then the brain then motivates you to get more opioids, and then you remember all those good times you had on opioids, and all you want to do is get more and more and more, and it's a kind of a vicious cycle to break out of. We'll talk a little bit more about that coming up. So monitoring parameters, again, we talked about it before, but the only way that we know if somebody's in pain truly is if we ask them. And pain control scales are something that we like to use a lot of. The numeric pain rating scale, we talked about that when we were going over our medications. The Wong-Baker-Faces scale, which we'll be able to see on the next slide. The FLAC pain scale, which is more for children from birth to 7 years. The pain AD scale, which is more for people with cognitive and pain impairment. Something we need to look at, mental status, alertness, again, looking for that somnolence, respiratory status. These things can cause respiratory depression, so we need to monitor the respiratory rate. The PA scale, Pacera opioid-induced sedation scale, which we'll see in a few slides. Blood pressure, again, like we talked about, morphine can cause vasodilation. And of course, with any time that we're dealing with opioids, signs of misuse, abuse, addiction, make sure our patients, if we're giving them oral, they're actually taking those medications and not cheeking them or giving them to somebody else. And then making sure that nothing's weird's going on with IV opioids, because I've heard a few interesting stories about that as well. So again, our numeric pain score at the top, and then our Wong-Baker-Faces scale. Sometimes we can't, or especially for our younger patients, we may not be able to put in words out of 1 to 10, but they can say, I feel like that. And this is something that we can kind of look at to help with our patients to kind of figure out where exactly we're at, as well as, okay, we're treating you, is it working? This is something we can always go back to.
That is so hard in practice, because people are.
It's always 10.
It's 10, it's 7, it's 8, it's 9, it's. And I'm thinking.
But you're saying they're comfortably with vital
Yeah.
signs.
Right,
You're
you're
having
green,
conversations.
your
really
respirations
deep.
are good, you're talking to me,
Yeah.
but we ask the pain, it's a 10 and I need something.
Yeah.
It's like,
Yeah.
so how in practice do you manage? You talk about all those extra things, and you can do these things, and
Something that my mother's an OT, and she would tell me about times that people would tell her, I'm in a 10 out of 10 pain. She's like, if you were at a 10 out of 10 pain, you couldn't be speaking to me right now. So it's just one of those things, giving real life examples of, okay, well, a 1 is this, a 0 is this, a 5 is this, and a 10 is this. So maybe giving them a little bit of reference to what these numbers actually mean.
Yeah.
In the end, there's no way for us to tell you, no, your pain's not a 10, because we don't know. And that's the problem with pain, and that's why this opioid epidemic has happened, is because people are going to tell you what they want. They may not be in pain, but they like the way that hydromorphone felt.
right.
And there's not a lot of ways for us to get around that, sadly.
So you're educated on the pain scale, and that ought to hopefully cover this.
Yeah, it's a
Being
hard thing to
neglectful
do.
for not addressing their pain.
Yes, and then you don't get your scores back, and the surveys, and because healthcare has kind of turned to a customer satisfaction oriented business,
Right.
and we have to make sure that our patients are taken care of. But sometimes we don't know when they're not being completely truthful with us, and there's not a good way. I apologize. There's not a good way to get around The POS scale, the Pacero opioid-induced sedation scale, I think it's a really interesting scale to use. So the sleep is, they're asleep, but they can be aroused easily. There's no really problems with it. They have increased pain. They're saying, man, I'm really hurting right now. We can always increase the pain there. So 1, awake and alert. We don't have to, there's no actions we really need to take that can increase. And even if we're getting to 2 where patients are slightly drowsy, but you can always wake them up and they're at least alert enough to have a conversation with you. If they have increased pain, that there shouldn't really be a problem, or maybe not increasing the pain treatment, but if we're doing a PRN, there shouldn't be really a problem of should I be giving this to them. 3 is where we're getting kind of into the point where we need to look at, are we giving them too much? So if I'm physically talking to somebody and they're drifting off to sleep and they're not able to keep their eyes open, when I'm having a conversation with them, we're probably giving them too many opioids. There's obviously a ton of other things that could get into this, but we probably need to look at possibly decreasing that dose a little bit, looking at other ways to manage the pain, such as NSAIDs, as long as they're not contraindicated. And then somnolent 4, minimal or no response to verbal or physical stimulation, shaking the patient, they're not waking up. As long as they're not having other problems and we're just looking at the pain side, we probably have given them way too much. And at that point, we probably need to be looking at naloxone. We need to be looking at, bringing other people in to monitor them to make sure that they don't progress and deteriorate. Another question here, physical dependence on opioids is most closely described in which way? Taking the same amount of medication yet having less pain relief, a desire to acquire or use drugs to feel happy again, or experiencing adverse effects such as shivering or nausea if an opioid is stopped.
C.
A is going to be tolerance, taking the same amount but getting the less pain relief. We're really looking for the dependence part, where if we take a route we have physical symptoms if that opioid is stopped. Opioid withdrawal occurs when patients are physiologically dependent on opioids, and we stop them cold turkey, or we greatly reduce the dose. It's really interesting with naloxone in that it can save the life of somebody that's having an opioid overdose, but then it can almost go the other way, where it can completely block
Then we
those
have to deal
opioids
with it.
and go right into withdrawal.
It's not
Yeah.
pretty.
So if we've had it happen before, we're saving their life, and then we're making them be in some of the worst pain they've ever had.
Yeah.
It's
But
such a
they're
bad
alive and
thing, but
miserable.
I guess being in pain is better than being dead.
Yes.
So don't ever hesitate to give the naloxone, but it is something that can happen. So what are they going to have at GI distress? Really, we're looking at diarrhea there, flu-like symptoms, sweating, shivering, shaking, tachycardia, anxiety, insomnia. And what we're really looking at is if they stop cold turkey, and we're not looking at a naloxone dose, 6 to 12 hours for the short-acting opiates, talking about fentanyl, hydrocodone, oxycodone. 30 hours for the long-acting opiates, we're looking at the extended-release version of those medications, or something like a methadone. And then we're really going to be peaking with those symptoms around 72 hours, and hopefully kind of decreasing over the next 72 hours, kind of making it through. So we can take up to a good week to really get through the complete withdrawal. And sometimes that goes longer, sometimes it goes shorter, but it's completely up to kind of how the patient responds to it. Talk a little bit about the opioid use disorder. This is a disorder that is diagnosed using the DSM-5 criteria, which we'll get to on the next slide. And the number of the symptoms that we look at is really going to be determining how bad of the opioid use disorder the patient has. So we're looking at some of the criteria, just to kind of show a few. The tolerance and withdrawal are things that we can almost kind of monitor. Whereas the tolerance, if we're given the same dose and you're reporting that you're getting less and less pain relief, we can document that as tolerance, right? Or withdrawal, if we stop giving you that opioid, we can document that when we stop the opioid, you had these symptoms, you had these withdrawal-like symptoms. But more so than that, it's almost the social situations that a patient will get into if they have this opioid use disorder, where they're constantly seeking the medications. They will give up on some of their social interactions, maybe ignoring friends or family, or God forbid, even kids, in order to get some of these medications. So they really they fail in fulfilling their obligations at work, school, and home. So these are some of the criteria. These are all the criteria for diagnosing opioid use disorder. If we have 2 to 3 of them, we're looking at a mild opioid use disorder. 4 to 5 is moderate, and more than 5 is severe. So this is kind of how our psych friends might diagnose somebody with an addiction problem, an opioid use disorder problem. Question 5, which scenario most describes addiction? The effect of the medication decreasing while maintaining the same dose. Primary chronic disease of the brain, reward, motivation, memory, and related circuitry. the body having negative effects of the opioid is stopped abruptly, or weaning off an opioid by reducing the amount of medication step by step.
B.
Yeah, we're going to be looking at B there. Chronic disease of reward, that positive feedback loop, and then kind of just spiraling out of that. All right, so we went through what causes pain, what is an opioid, how do we give these medications to our patients in a safe manner. So just kind of shout them out. Who are people that can prescribe controlled substances?
Nurse practitioner.
That's right. We're gonna kind of lump mid-level practitioners in there. So we got 4 more categories. Can anybody name one?
Well, we have them on our paper. We have them on our papers. So.
I'm sorry. I thought I was trying to be all crafty here with an animation. So we're going to be looking at physicians, dentists, podiatrists, and veterinarians. Veterinarians are actually coming under a little bit of fire. There's some legislation out there that's trying to stop them prescribing opioids because a lot of times patients will say, my dog is having severe pain, and they will take their dog's medication. It sounds crazy, but
I'm not surprised.
No, I had a patient who I have no idea, she would utilize large doses of diuretics. So she actually had 2 large dogs, and she was getting, when we were trying to wean her off the diuretics, she was then going to her veterinarian to get additional diuretics to be able to use it. And it was
Antibiotics.
crazy.
I've had patients take their dogs antibiotics.
Yep.
Yeah.
I had a patient, she had 2 dogs, both of them were on 360 tramadol a month.
Holy cow.
And I'm sure that they were getting every single one of those.
I'm
pills.
sure those dogs
They
were
were-
well
I'm sure.
Yeah, so
They had no
controlled with
pain.
their pain.
Yeah, so I
They
mean,
had no pain.
they can't even.
Funded.
The problem with that is that our patients, the only way we can find out if they're in pain is they tell us. You can't. The dogs can't even tell you that.
Yeah.
So it's just like all they have to rely on is the owner, and when the owner comes in and says, "My dog's in pain," what are you gonna do? Say, "No, your dog's not."
Right.
Like that's such a hard. So there's some people looking at the opioid prescribing of veterinarians here recently.
Wow. Would have thought about it.
I know. We actually see it quite often on the retail side, or the outpatient side. And what are you going to do? Say, no, I don't believe you. Your dog doesn't have this. I'm not going to fill this prescription. You can't do that. So, anyways, it's an interesting kind of little quirk to this whole epidemic. So before starting therapy, we really need to establish treatment goals. Telling a patient that they are going to be pain-free when you give them these opioids is not something that we should be doing. If patients are expecting that they will be completely 100% pain-free, as soon as they have that slightest tinge of any kind of pain, they're already coming back and said, you told me I was going to feel pain, I need a higher dose, I need more of this, because you told me, no, that's not what we need to be setting up. We need a setup of, you may still be experiencing some lingering pain, this will be able to take care of most of it, and as you progress through your recovery, your pain should lessen and less, and as should be your intake of pain medications as well. Reviewing risk versus benefits. So obviously the benefits of helping the patient not being in pain anymore, but the risk, there's a ton of risk with opioids. We're looking at misuse and diversion here. We're looking at the side effects of addiction, tolerance, withdrawal, somnolence, taking too many, we're going to be looking into respiratory depression. So we really need to say function is the goal. You may not be able to get 100% of your pain completely wiped away. We're going to get most of it. And I want to get most of it. I don't want to overload you on them because I want to protect you. I want your safety at the forefront of my mind. Evaluate risk for opioid-related harm. Risks, we're looking at watching for history of overdose, monitoring for higher opioid dosages, so we're looking at more than 50 milligram morphine equivalents a day. So if you do that opioid conversion table, convert it into morphine equivalents, we're looking at more than 50, kind of making sure that we're talking to those patients specifically about risk and benefits. Concurrent benzodiazepine use, I see this all the time in our elderly population. People are on alprazolam and lorazepam and hydrocodone, and it's such a terrible combination. Patients with sleep apnea or sleep breathing disorders, because they're already having trouble breathing, we're going to be giving them medications that can cause problems breathing, and that's obviously just going to be adding together there in pregnancy. And lastly, reviewing prescription monitoring program. We'll get a little bit more into that at the end of the presentation. The Illinois PDMP or PMP, prescription drug monitoring program, is something that I use every single day on my side, and it's something that I hope prescribers are using here as well. It's a great tool for us to be able to see this patient filled this controlled substance at Walgreens or Walmart 2 days ago, and yet they're coming and telling, and and it tells you the day's supply as well, and they got a month's worth. Now they're coming in here and telling me that they've never had an opioid in their entire life. Something's a little off there, okay? And that's something that we look at as well. So like, if I know that you're getting it somewhere else and you're coming to me, I can check that and see, I think you actually got this at Meyer. Is that the case? Oh, well, no. It's like, come on now. But we're not trying to be the gatekeepers here. We're trying to make sure that our patients are safe and that they're not having any harm befall them.
Do they have to show their ID to get the opioid medication?
Any controlled substance requires 2 forms of identification.
Oh,
One
okay.
we usually do like name, birthday, and the second one, at least at my pharmacy, we'll always do driver's license.
Okay.
Yep. Driver's license or state ID, I should say, because not everybody has driver's license. So initial prescribing. So non-pharmacologic, non-opioid pharmacologic therapy are preferred. I think we've already talked pretty well about that. We use the immediate release opioid products initially, but there's no reason to really jump to ER or or extended release or long acting if they've never had an IR, because there's actually studies that have shown that the more scheduled approach of opioids, take this one every 12 hours, will lead to much more ingestion of opioids over a longer period of time, rather than if you take a PRN dosing schedule, right? So they only take this when necessary, even if you have the ability to take it sooner than every 12 hours, every 4 to 6 hours, say. Most patients will take less of it than you say, no, you take this every 8 hours on the dot. So really looking at those dosing schedules, reserving the extended release products for the severe, continuous, that maladaptive pain in opioid tolerant patients, and this is so important, lowest dose for the shortest duration. The CDC actually recommends that most acute pain problems can be solved with 3 days of opioids, and hardly ever will we ever need to go above a 7-day supply of opioids. And this is, again, to make sure that we aren't creating any kind of diversion or misuse by having this large supply of opioids at home. I mean, how many times have you gone to one of your parents or an aunt or uncle's house, and they just have, like, I've gone to my dad's house, he just had a bottle of oxycodone in there from a surgery from 10 years ago. It's like, Dad, why do you have this? He's like, well, I only needed 2 of them, and there's 30 left. Like, there's no reason for us to be doing that.
So we're in cardiac surgery, and like when I started working with Dr. Christie 10 years ago, we would just give 90 tramadol to every patient, whether they were 30 or 80. And now we do like a CU7 follow-up, so we'll just give them only a week's worth,
Absolutely.
the lowest amount, and then when we see them if they need more. But most of the time, they're not even taking that, and they don't need a refill. So.
And that's where that treatment goal, that treatment plan.
It's like a huge change in our culture.
Absolutely, and the more that our prescribers are willing to do those things and do those follow-ups, the less supply we're going to have out with our patients, and then consequently out on the streets. Because where are the patients getting them? They're getting them from all these prescriptions most of the time. And then avoid combination of benzodiazepines. There's a study saying that there is a 4 times greater risk of fatal overdose if the patient is taking an opioid with a benzodiazepine. So it's a super common thing in our elderly population, and it's something that we need to look for. And we can look for that on the PMP as well. So the PMP is not just pain medications; it's any controlled substance. So we can see if they're taking benzodiazepine, because they may not tell you. They don't want to be upfront about that stuff because it feels good, but it puts them at risk. Question 6. True or false? When treating pain, non-pharmacologic or non-opioid treatments should be considered first.
True.
That was kind of a soft lob there, so I hope everybody hit that one out of the park. Question 7. You should prescribe opioids for the blink duration at the blink dose. Longest, highest, shortest, highest, longest, lowest, shortest, lowest.
Shortest, lowest.
There we go. I like it. Very, very important thing. We don't need to be giving our patients a ton of opioids if it's not going to be necessary, especially if we're doing follow-ups. I think that's such a great thing. Question 8. Which of the following medications with parallel opioids can quadruple the risk of fatal overdose? Benzos, beta blockers. You got it. Please, direct 10A inhibitor.
Beta blockers.
So benzos. All right. I know that I'm getting close on time, so I'm going to hit some legal requirements first. So these are the things that I'm going to be calling you from the outpatient side. I'm going to be bothering you, and you're going to hate me. But sadly, I have to get all these things on the opioid prescription in order to process it correctly. So date and signature, we need a wet signature on everything unless we're set up for e-prescriptions of controlled substances. And for that, I'm talking about C2, C3 or 3 through 5 is a little bit different. Prescriber full name, address, and DEA. We always have the DEA number, so if you have an outpatient pharmacy calling you for DEA, I promise we're not trying to bug you, but if we don't know the DEA, we can't fill the prescription. Drug name, strength, dosage form. Quantity and C2s. On quantity, C2s we're going to be looking at hydrocodone, oxycodone, and more of those high-powered opioids. The quantity actually has to be numerically and alphabetically. Okay, so if we're 3-0, we also have to write it out alphabetically as well. Directions for use and number of refills, if any. We'll get a little bit into the refill problem in just a second. Right here. So just kind of looking at the C2s through 3 through 5s, concentrating on opioids. The C2s are going to, again, hydrocodone, oxycodone, hydromorphone, fentanyl, morphine, methadone, all the really big heavy hitters. 3 through 5, we're going to be looking at our Tylenol 3, 4s, and this is also where our benzos are going to fit in as well. So day supply on a C2 prescription can only be a 30-day supply. It cannot go over 30 days. The only way around that is to write 3 separate prescriptions for 30 days apiece and have fill dates on each one of them. That's the only way that we can prescribe more than 30 days worth of C2 at any given point. C3 through 5, the day supply can get up to a 3-month supply, 90-day supply. Expiration date on C2s are 90 days from the date that it's written. C3 through 5s are 180 days. And then delivery methods, so the C2s, on the outpatient side, they can only be written or e-prescribed. I don't get a ton of e-prescribed C2s. Once in a while we'll get one, but most of the time it's going to be written and we need that wet signature on there with a pen.
I don't think we can e-scribe C2s through Epic.
And not every system is set up for that.
Right.
But I'm
And I
saying
know
that it is
others-
a possibility.
Other states accept, so Illinois does accept an e-scribe for C2s.
Mhm.
Okay, but I don't think our EHR
Yeah,
allows it.
yeah,
It has to be,
set up.
which doesn't really make sense to me, an
So
e-scribe
we have
is
to get a
safer.
script. Do you guys still have your hand scripts? no?
Or it's on the watermark paper,
Mm-hmm.
It prints and then we have to
Yeah.
sign it.
sign it.
Yeah.
Exactly. And then C3 through 5 would be written, e-prescribed, telephoned in, or faxed in. So special prescribing situations, a prescriber may fax a C to a pharmacy to expedite dispensing, but the pharmacy may not dispense that medication until we have that handwritten script in there. I've had this once or twice on the outpatient side, where I know that an inpatient will be discharged very shortly, and I'll get the prescription faxed to me, and I'll say, okay, I can go ahead and get this ready, but I will not be able to give this to the patient unless they hand me that handwritten script. So it's just to facilitate, ease of discharge, ease of getting them in and out of the pharmacy in a quick manner. In an emergency situation, I've only ever had this happen to me once. A prescriber may phone in a prescription for a C2. The amount can only be enough for the time that will cover the emergency situation. So we're talking about a few hours supply or a few days supply, at the very most a few days. And at that point, handwritten prescription has to be in the pharmacy within 7 days. And it only happened to me once. The patient was in a very bad car wreck, but they didn't go to the hospital, but they lost all of their C2s and they were there and they didn't have any kind of pain medication. So I had a doctor phone me in a script and the doctor actually drove down and gave me the prescription after. But I had to take care of that patient right there in that moment. And I knew the prescriber fairly well, so we were able to facilitate that, to take care of our patient. Question 9, what is the maximum day supply that a prescriber can write on a single C2 prescription?
30 days.
30 days, you got it. Again, we can get up to that 90 day if we write 3 separate 30-day prescriptions, but I normally only really see that with some of our ADHD medications in our younger population. How many days is a C2, I'm sorry, that should say C3 through 5 prescription valid from the date that it is written? Again, 3 through 5.
180.
I don't know.
Oh, we gotta go back to our notes, huh?
Yeah,
It's valid
notes
for,
here.
it's valid for 100.
180.
180, you're exactly right. So with
Oh, expiration.
Try to trick us.
Not trying to trick you. C3 through 5s, we can do 1 month with 5 refills or a 90-day supply with 1 refill, so we're good up to 180 days on. In a pinch, you can mail a controlled substance, but they can't be outwardly dangerous. The outer container can't say, this has oxycodone in it. The inner container must be labeled.
Yeah, the postal service gets really
And
excited
it
about
probably is not going to get there. The inner container must show the name and address of the pharmacy or practitioner that is dispensing the medication. I think I've only done this once to somebody who refused to use a pharmacy down in Florida. They were a snowbird, and we mailed it to them. It was an odd situation. The PMP, again, this is something that is so incredibly important on the prescribing side and on the pharmacy side. As of January 1st, 2018, all prescribers having a controlled substance have to be registered. Each prescriber can have up to 3 designees as well. So if we have people that are non-prescribers, they can go to one of their prescribers' friends that they work closely with in the same office, and they can actually get access to the PMP through the prescriber's access. It's an interesting kind of little caveat there. So like I could give my technician access to the PMP if they would like.
Our nurses have it.
Wonderful, yeah, it's great. And if checking the PMP, the patient used 3 or more pharmacies or prescribers for controlled substances within 30 days. The PMP can actually issue a report to the prescriber of the pharmacy. I have never had this happen, and I've had a ton of patients that have gone doctor and pharmacy shopping, but they do reserve the right to kind of say, hey, by the way, your patient that you just filled hydrocodone for has filled it with 3 other pharmacies in the last 30 days.
Yeah,
They
I've had
have-
pharmacists call me on it before.
Yes, because the pharmacies,
Hey, did you
yeah.
know? I'm like,
The pharmacists are actively checking it. Meanwhile, this is run by the state of Illinois, and they probably don't have enough manpower to really
yeah, I love
To
it.
do this
The
stuff.
cat ate it.
Yeah,
That was
they-
the best one.
cat needed it to flush down the toilet.
Did
I
it
dropped
die?
it.
Still living?
Yeah.
Cat's still living? Yeah, cat's living.
So wrapping up here with just a few important counseling points. Adherence to the prescribed dosing regimen. Again, we really want to watch for those signs of misuse. Using the least amount of medication, the shortest day supply with the lowest strength. We get counsel on the serious adverse effects of respiratory depression. Decreased situational awareness, so we're talking about driving cars, operating machinery, things like that. If you're feeling out of it, drowsy, please don't tell your patients to not even risk it. It's not worth it. Because at that point, you're not just putting yourself at harm, you're putting other people at harm. Risk of addiction, importance of full disclosure to the medications provider. Again, we're looking at that benzo thing. If you're not telling me that you're on alprazolam and I prescribe you opioids, you're at such a higher risk of overdose, and I'm not going to know that unless you tell me, unless I'm looking at the PMP. Never sharing opioids, how to use naloxone products if appropriate. Don't ever be afraid if you think that there could be an issue with misuse or abuse to give your patients a naloxone prescription. There's not a lot of harm that can come from those prescriptions, and it can save a life if necessary. There are a few people that say, well, if I give them the naloxone, they're gonna overdose, and it gives them the ability to do that. We're looking to save lives here, and if they're gonna overdose on it, they're probably gonna try to do that anyways. So let's try to protect our patients. Let's try to make sure that they know that their safety is the number one thing that we're trying to kind of put forth. In summary, pain is a multi-step process, and it's not something that this one thing causes this and that's how pain happens. We went through, there's 5 different steps to adaptive pain. Maladaptive pain is just a mess in general. So there's so many different things that can cause it, and that's why every person that has pain is just a little bit different. Treatment of the pain does not have to be always centered around opioids. We can do non-pharm, we can do non-opioid. When prescribing opioids, always talk to your patients about the adverse effects. Yes, we at the pharmacy are always going to be talking about those things as well. And I talk to every single patient that has an opioid about these really major adverse effects. But the more people that talk to them, the better it's going to be. Giving the lowest dose of opioids for the shortest duration. Avoid prescribing benzodiazepines. I can't say that enough. Please watch out for that. And then always checking the PMP before we're giving the opioid prescription. So that's kind of where I will end that one. So I think the rest of the time we have for some discussion, some questions, and hopefully I can answer to the best of my ability.
Did everybody get their quiz filled out? Okay.
In the outpatient setting, I see a lot of the neuropathic pain for the wound care, and just I've been trying to get them to do the topical creams and all those types of things. They seem to be reluctant. They tend to want the pill.
That's because they were originally given the pill.
Yeah.
And they know what that feeling
Yeah.
starts like. So it really is us as a medical community making sure that we're trying to start them off on things that are not that, the non-opioids, the non-pharm, so we don't get them hooked on these things early, right? Because even when I was in high school, people were getting football injuries. I knew people in high school that today are heroin users because they got hydrocodone for a broken ankle from a football injury. Yeah, exactly. And because we're giving out these opioid medications to these people so young, and they get that gratification sense, they get that addiction problem in the very beginning, because it's very easy to do because it takes away that pain. And if it takes away the pain, it makes you feel happy, and everybody wants to feel happy. So it really starts at the very beginning, and you can't help if another prescriber has given them the opioids in the past. You can do your best job to make sure that you're doing the right thing as well.